Hey there, everybody, and welcome to today's presentation on obsessive compulsive and related disorders in the DSM-5-TR. Today, we're going to review the disorders in the obsessive compulsive and related disorders category, explore the diagnostic criteria for OCD and hoarding disorder specifically, and identify associated features and alternative or differential diagnoses of the disorders in this category. This category also includes body dysmorphic disorder, which we won't dig into too much today. We'll save that one for the eating disorders lecture. Trichotillomania and excoriation disorders are also in here. So that's hair pulling or skin picking, substance-induced obsessive compulsive disorder or other specified obsessive compulsive and related disorders. And the DSM-5-TR includes this with nail biting, lip biting, cheek chewing, obsessional jealousy, and olfactory reference disorder. Olfactory reference disorder is when you believe that you're emitting an odor that everybody else can smell, even though they can't really smell it. You believe that you're emitting it, and the person who has olfactory reference disorder may go to great lengths to try to mask that smell that they believe that they're emitting. So let's talk about some prevalence here. The prevalence of obsessive compulsive disorder in the DSM-5-TR is identified as 1.2%. And when you look at the research up until 2019, 2020, that was pretty stable, and it seems to be pretty stable across cultures. However, when the pandemic hit, post-pandemic, we've seen an increase in obsessive compulsive disorder symptoms in the general population, ranging between 60.3 and 62.4% of people in the general population. This is not just healthcare workers. This is not just people with comorbid mental health issues. This is the general population. So let that sink in for a second. It doesn't necessarily mean they all rose to the level of meeting the diagnostic criteria for obsessive compulsive disorder diagnosis, or that they continue to meet that. However, living through the pandemic, I think we can safely say the majority of people who developed symptoms probably did, at least during that period, meet criteria. Now, whether you would diagnose it as OCD or illness anxiety disorder, we're going to talk about that later, but I think it's really interesting. However, I said the prevalence of OCD symptoms skyrocketed. They did, but it was only related to contamination and illness-related symptoms and not the other types of obsessions and compulsions, such as ordering or safety or things like that. What the take home is for you, you who want to go into private practice or even working in clinics, is that you're probably going to see a lot more people with OCD symptoms. And my guess is that, just from clinical experience, not the DSM-5 here, but my guess is that when we start to approach the next flu season, we may see an uptick in OCD or illness anxiety related behaviors that we may need to pay attention to, because it can be extremely disruptive to a person's life. And we'll get into that when we talk about treatment. Excoriation and trichotillomania represent about 2.5% of people. So 2 to 3 people out of every 100 struggle with excoriation and trichotillomania. Now, we want to differentiate that from body dysmorphic disorder, and there's a whole lot of overlap there. So again, we'll talk about that. And hoarding disorder impacts approximately 2.6% of people in the general population. So let's start out by talking about obsessive compulsive disorder. This is the umbrella diagnosis for this chapter. The person has to have the presence of obsessions, compulsions, or both. So to be diagnosed with obsessive compulsive disorder, they don't have to have both. They can have obsessions, compulsions, or both. That is a common misconception that people have when they're making the diagnosis. Obsessions are defined as recurrent and persistent thoughts, urges, or images that are intrusive and cause marked anxiety or distress. The person tries to ignore, suppress, or neutralize the thoughts, urges, or images through behaviors or activities or other thoughts that they engage in. And those suppression behaviors are the compulsions. Compulsions are repetitive behaviors or mental acts people do in response to an obsession or according to rigid rules. So there's a little or in there, not an and, but an or. They may do it in response to an obsession. So they have this intrusive thought or intrusive image, and they start engaging in this compulsive behavior or mental act in order to get that out of their head. However, some people with obsessive compulsive disorder may adopt rigid rules for things that they have to do in order to prevent the onset of obsessions, in order to prevent bad things from happening. So, the rigid rules, especially in someone who has long-standing obsessive compulsive disorder, may account for people's prevention sort of strategies. They're trying not to have that thing happen. They're trying to engage in whatever activities or mental acts they need to do in order not to have those intrusive thoughts or images. Compulsions are aimed at preventing or reducing distress or preventing a dreaded event. However, these behaviors or mental acts are not connected in a realistic way with what they're designed to neutralize or prevent. A common example, people may fear stepping on cracks because they think it will cause some sort of catastrophe. There's no connection between stepping on cracks in the sidewalk and causing a catastrophe, but that can become a very common obsession in obsessive compulsive disorder. Therefore, the behavior of avoiding stepping on cracks may become very prominent, or the behaviors may be connected but clearly excessive. So instead of washing your hands once for 20 seconds or a minute with warm water and soap, the person may wash their hands 20 times and then still not be certain that they've accomplished the task to the best of their effort. It's important to note, if you're trying to diagnose OCD in young children, they may not be able to explain the purpose of these behaviors or mental acts, but they still may need to do them. And that makes it a little bit more difficult to differentiate from autism spectrum disorders, where there are repetitive behaviors and difficulty with changes in routine. But it becomes apparent when you're taking a much greater longitudinal assessment of what's going on, whether it's obsessive compulsive disorder or autism spectrum disorders. And obviously, in OCD, a lot of the symptoms of autism spectrum disorder are not going to be there. Obsessions or compulsions take more than 1 hour per day or cause clinically significant distress or impairment in one or more areas of functioning. It's important to recognize that this is another one of those or clauses. It can take 1 or more hour per day, which is deemed excessive for whatever it is, or causes clinically significant impairment, or both. But you don't have to have both. The person's behaviors can be egosyntonic, and it may not cause them clinically significant distress in how they report, right? They're doing these compulsions to prevent something bad from happening. It may cause them clinically significant impairment by another person's assessment. So we do want to recognize that, and symptoms are not attributable to physiological effects of a substance, a medical condition, or another mental disorder. Content of obsessions and compulsions can be just about anything. However, some common themes include contamination from bodily fluids, from germs, from toxins in the environment, and the person may engage in behaviors like cleaning or changing what they do, like washing their clothes in order to get particular chemicals out of them, and reassurance seeking from doctors, from other people. Is it clean? Is it clean enough? Did I do it well enough? Symmetry, straightening, ordering, and counting compulsions are also common. Symmetry, where if you're looking at it, it must have equal space on either side. And if it's symmetric or if it's asymmetric and there's an imbalance, it may cause them to stress. And I pulled this video from Instagram as sort of an example of this. This is the kind of stuff that really grinds my gears. It makes me feel really anxious. And it's been shared so many times on social media. I see I'm not alone. Just because this might be bothersome to you doesn't mean that you have OCD. But I do think it's cool just to think about how there's something hardwired in us to want order and cleanliness and clean lines and symmetry and balance. Now, where there's distress, we need to explore what's going to happen, if there's no symmetry or order. Same with straightness. And I know there's a lot of people who are particular about, hanging pictures and making sure that they're level at home. And if they're not level, it really just bugs them. But does it rise to the level of causing clinically significant impairment? And does straightening things or leveling things take more than an hour a day? For most people, the answer is no, but it may be something that's frustrating to the individual because the straightness and it just bugs them and they can't seem to let it go. So is it causing them, clinically significant distress? Taboo thoughts, and this can be religious thoughts, aggressive thoughts, sex thoughts, whatever the thoughts are that the person perceives as bad or taboo. This could have some cultural implications too. What you may not see as taboo, your client might, and they might engage in related compulsions to either atone for those thoughts or to make those thoughts stop. Regarding harm, people may have obsessions about harm, about a fire happening, about somebody breaking in, about getting in a car accident, anything that could cause harm to themselves or somebody else, which may result in checking, making sure that they've turned off the iron or the stove or locked the doors, and reassurance seeking. Discarding objects for fear of harming others is another common content of obsessions and compulsions. Some people believe that if they discard some object, that is somehow materially connected to another person. So if they discard that, it actually physically injures the other person. And we're not talking about if I throw away the clay vase that somebody made me, it's going to hurt their feelings. We're talking about if I get rid of this, it's actually going to cause physical harm to that person. Losing control and acting on impulses is another fear, whether they fear that they're going to act on aggressive or sexual impulses or just lose control in the middle of somewhere. And losing control is a common concern for people with agoraphobia too. So you want to make sure that you're differentially diagnosing what's going on. Losing or forgetting something important is another obsession that people can have. We want to differentiate this from other diagnoses like ADHD, in which losing or forgetting something important is very common due to low executive functioning, and they may not have many compensatory strategies to help them avoid doing that. And that may cause them a fair amount of anxiety. And finally, incompleteness, not feeling like they can get rid of something and that they're losing themselves. So, this is obviously more prominent in hoarding disorder, but if they get rid of a photo album or if they get rid of their high school textbooks or they get rid of something else, they may actually fear that it takes a part of them with it. Hoarding disorder, persistent difficulty parting with possessions regardless of their actual value. A lot of people with hoarding disorder have collected things for a long time, and some of these things may be even old newspapers and not from significant events, but just old newspapers or old flyers or even takeout menus that they've accumulated over the years. The difficulty is due to a perceived need to save the items. I need this just in case. And to avoid the stress associated with discarding the item, they think they need it and they're afraid that, they might experience distress if they discard it. And it stresses them out if they get rid of it because they start wondering, well, what if I need it again? So there's a lot of anxiety and distress associated with parting with that thing. The difficulty discarding possession results in cluttered, compromised living areas. Now, this is important. There can be a little bit of clutter, and there's a lot of clutter in attics and basements of garages, closets. That's not what we're talking about. We're talking about in hoarding disorder, it must be to the degree of the clutter. It must compromise or spill out into living areas. So maybe completely covering the dining room table. So you've got to move stuff out of the way in order to even just sit at the table, or not being able to sit on the sofa because there's so much stuff. You've got to move it onto the floor, if there is a spot on the floor to move it onto, just to find a place to sit. So that's what we're talking about. If living areas are uncluttered, it's due to the intervention of third parties. For children, this may be their parents. For adults, this may be significant others or cleaning crews that they've hired to come in. However, after the cleaning crew leaves, they start collecting more stuff again. And a lot of times, the person with the hoarding disorder is not going to intentionally hire a cleaning crew because that cleaning crew would separate them from their stuff, which would cause the distress. Hoarding causes clinically significant distress or impairment and is not attributed to another medical or mental health condition. Now, not as a part of the diagnostic criteria, but in the write up of hoarding disorder, one of the things that we need to notice is that 80 to 90% of cases may have something called excessive acquisition, which means they just get too much stuff and they keep gathering stuff. It's not like they get something like a textbook from high school or college and they keep it and they have difficulty parting with it. They're actually ordering more textbooks, they're ordering more stuff than they actually need or might realistically fit in their living environment. Separation from items or prevention from acquisition of new items may prompt distress. And this is important to recognize. So we need to explore what the meaning is of this behavior. What function does this behavior serve? And it's important to recognize that most obsessive compulsive and related disorders are contributed to by experience of trauma. Therefore, we want to ask ourselves, remember, trauma strips people's sense of safety and empowerment. In what way do the compulsions Or in what way does the hoarding or the skin picking or the hair pulling contribute to that person's sense of control and safety in their environment? And I had a client a few years ago who I was seeing for substance use disorders, and she had a significant history of incarceration. And on the outpatient level where she was seeing me, she disclosed noticing hoarding behaviors in herself that were new because you can't really hoard while you're in jail. But she noticed that she was buying tons of soda, Gatorade, water. Really, it was limited to drinks, but she would drink them, not drink them. It didn't matter. She would save them. She had a car with tons of bottles in it. Her purse was full of bottles, her home littered with empty bottles, full bottles, all of it. And we talked a lot about, where is this behavior coming from? It's coming from when she was in jail, when she was in active use. She had no control over her food intake. She talked about always feeling so thirsty and having water or anything to drink. So, yes, her behavior now stemmed from a long term traumatic experience where she was not in control and hurting. That she was able to be honest and vulnerable and put words to her feelings was really the first step. And then we started looking at discarding only the empty bottles. And, like we discussed, there was a lot of anxiety associated with even getting rid of the empty bottles. So we looked at anxiety in treatment sessions. We used positive imagery, mindfulness, and meditation to help ease her distressing thoughts and feelings while she was cleaning. And another criteria or part of hoarding disorder is animal hoarding, which includes accumulation of a large number of animals and failure to provide minimal standards of nutrition, sanitation, and veterinary care. Many people who hoard animals also hoard stuff. We want to look again. What might this behavior mean? Most people who hoard animals, it's not like they're collecting them thinking this would be neat or that would be neat or that one's cute. Most people who hoard animals, they're hoarding the rejects. They're hoarding the homeless animals, the ones who are injured. They're hoarding the ones that just get dumped. So we need to look and see, how does this parallel? Those animals, how do those animals parallel with that person? They may not be willing to get rid of the animals or adopt them out. So how does that mean to that person? The person says, I'm the only one who can guarantee that this animal is going to be loved, even though objectively that may not be what's happening. And if that's going on, we need to ask ourselves, in what way is this a recapitulation of this person's childhood? Maybe nobody took care of them. Now they're trying to take care of all the discarded and injured and unwanted animals. So we want to look for parallels because behavior has meaning. In terms of the development and course of obsessive compulsive and related disorders, the mean age onset of OCD is 19.5 years, and the mean age onset for hoarding is 15 to 19. So, what we're seeing is a mean age onset in early to mid adolescence. Well, let's think about what's going on here. This is a time of individuation. This is a time of, stress and identity development. This is a time for huge hormone swings and a lot of turmoil for a lot of people. How are the biological changes? How are the cognitive changes? How are the social emotional changes that are happening in the individual? How are these all contributing to the development and course of OCD? Are there triggering events that are happening more in this time frame? Were there traumas that happened? Was there superstitious reinforcement? Maybe there was. Think about maybe like taking a bath and something bad happened. So now they won't take a bath, or they've got to do a certain set of rituals before they can take a bath. And because that trauma is far away now, their behaviors are reinforced, right? They they're looking at, I brushed my hair 1,000 times before I got into the bath, and the bad thing didn't happen. It must be working. That's superstitious reinforcement. As an observer, we can see that those two things, brushing my hair and taking a bath, there's no connection. But, the person has made that connection in their head. And it's important to recognize, especially in younger people, that superstitious reinforcement is not uncommon. So we need to, in treatment, eventually help them uncouple or unhook their responsibility and their sense of heightened power in different events. Symptom onset for OCD is typically gradual. However, acute onset can also occur. During the pandemic, we saw a lot more acute onset where it became very overwhelming very quickly, and people started worrying about everything. However, onset may be gradual, where they start worrying about germs and washing their hands, and then, maybe they wash their hands, but they got sick anyway. So now they worry about germs, and washing their hands once isn't enough. They need to wash them twice or three times. So you can see how this might develop over time. If they engage in a behavior to prevent harm and that behavior fails to adequately protect them, they may develop alternate behaviors or intensify that behavior in order to prevent it in the future. One of the treatment suggestions I've heard here, like with anxiety disorders, is that systemic desensitization, or in this case, it's called flooding, where you have somebody who washes their hands three times, for example, you have them continue to wash their hands until the hand washing creates some distress. And that's a way to start to uncouple the behavior with the responsibility of events. And I don't know how I feel about this one since we're sort of bordering on causing harm or distress. It's not something I'm well versed in, but there is some research to support it. So let's talk about trichotillomania and excoriation. So hair pulling and skin picking, recurrent hair plucking resulting in hair loss. Now this is important, and this is the clause about causing clinically significant distress. If you're plucking your eyebrows, yes, that may lead to hair loss in areas where you want hair loss. So that's not what we're talking about. We're talking about reoccurrent hair pulling resulting in permanent hair loss, or skin picking resulting in lesions, resulting in sores in the body, and unsuccessful attempts to stop. So, obviously, this isn't something that the person wants to be doing. It's causing them clinically significant distress, and it's not due to another medical condition, substance use, or a mental disorder, including body dysmorphic disorder. And we need to differentiate carefully. Body dysmorphic disorder has to do with the person identifying a flaw that they perceive that nobody else sees, or a flaw that they perceive as huge and it's only minimally noticeable to other people. And in that case, they may engage in hair plucking if they think there's a hair or something grotesquely growing out of their face or what have you. And substance use, especially the stimulant family, cocaine, crack, meth, that often leads to skin picking too. Heroin, or if a person is injecting any substance, can also lead to some skin picking of scabs, sores, abscesses, track marks, etc. So even think about prescribed medications. Some ADHD meds can create small allergic reactions like hives on the skin, and these can be the target of skin picking. So be careful to look here for substances, medications when you're making a diagnosis. Pimples or other things that are just grotesque to other people that may be more in line with body dysmorphic disorder. Skin picking can include picking at pimples and scabs and other things like that. And like I said, we're not going to go deep into trichotillomania and excoriation, but it is important to note that this can be seen in stressed out students fairly often, especially during tests and exams. So as you're studying for your NCEs, pay attention to what you're doing with your body. Pulling out eyelashes while students take their test, or pulling out hairs on their arm, or pinching with their fingernails, making sores or lesions on their arms. This isn't non suicidal self injury. This is simply picking and squeezing at the skin. But those are behaviors that can exacerbate, and they can become very problematic if we continue to do them often and over time. And if they're in places where other people can see, they may become very embarrassing to the person. So we do want to recognize the importance of addressing some of these things. Differential diagnoses. So, hoarding disorder is pretty self explanatory. The person collects stuff and it significantly clutters and compromises their actual living space, and separation from that stuff causes significant distress. And inability to collect more stuff may also cause them significant distress. So, it's a little bit different than the obsessive compulsive disorder. Trichotillomania is hair pulling, and sometimes it's intentional. Sometimes the person will pull hairs and eat them. Sometimes they'll roll it around in their fingers. There are people who may do it very intentionally, but there are people who will do it relatively unintentionally. Same with excoriation. Body dysmorphic disorder, the focus is on a perceived flaw that's not observable or only minimally noticeable to others. We do want to recognize that they may spend hours a day trying to cover this up and engage in checking behaviors, but it's related to this one perceived flaw. Eating disorders. The focus is on food and weight. There's a restriction of caloric intake in anorexia and a disturbance in the experience of body shape or weight. They have a lot of obsessions about their body, about weight, about fear, about fat, and fear of rejection. And the obsessive compulsive behaviors revolve around controlling body shape and controlling food intake. Illness anxiety disorder is diagnosed when somebody has a preoccupation with having or developing an illness and engaging in excessive health related behaviors like going to the doctor multiple times, seeing multiple physicians, concerned with hand washing, and what you might call home based rituals. Differentiating some of these disorders, eating disorders, illness, anxiety disorder from obsessive compulsive disorder can be very tricky. And I would encourage you to really look at the symptoms that the person is experiencing. The diagnosis is there in order to potentially help guide treatment. The symptoms are what the person is dealing with, and helping them address their symptoms as they're presented instead of getting too caught up in a diagnostic label is important, because what works in treating an eating disorder or OCD or hoarding disorder for one person may not work for another person. There's no one size fits all treatment plan for each diagnosis. We need to make sure that we're individualizing. Other things that we need to rule out or rule in, there can be some comorbidity here. Generalized anxiety. So, with generalized anxiety, the person has a variety of worries, a variety of anxiety about a variety of things most of the time. So, they typically don't have compulsive behaviors with them. But remember, in OCD, you don't have to have obsessions and compulsions. So, again, your differential diagnosis, it might get a little dicey here. Major depressive disorder, guilt, and depressive ruminations, these things are mood congruent and tend to not be what you would call intrusive. They're just not having a great day, and all of a sudden they have this intrusive thought. They're down in the dumps and they're feeling really depressed, apathetic, and they might have those persistent thoughts that are going through their head, but those thoughts will remit when the depression remits. Postpartum depression, and this one wasn't mentioned in the DSM 5 TR, but I think it's really important to note that a lot of people, not the majority, but a lot of people who develop postpartum depression may have intrusive or scary thoughts as a result of those thoughts. They may engage in some compulsive compensatory behaviors in order to try to keep themselves and their infants safe. Treatment is definitely important when the behaviors are egosyntonic, and that is that the images that they're having, they believe they are true and real. That is an indication of postpartum psychosis and needs immediate medical intervention. If their intrusive thoughts, their scary thoughts are ego dystonic, they're having these thoughts and they're like, no way, I would never do that, or that makes no sense. That's an indication of postpartum depression. However, it's something that needs to be addressed so the person doesn't start a cascade of developing compensatory behaviors. There are treatments that the OBGYN or their general practitioner or psychiatrist can help them with in order to manage postpartum depression. Substance use disorders. This is an obsessive nature about substances, and the compulsion to stop these cravings is to use. But this is not distressing. We're not having intrusive, distressing images. The person is obsessing about, hey, where do I get my next hit? Their dopamine levels drop, their body prompts a craving that leads them to compulsive behaviors in order to try to satisfy that craving. So that's different. Gambling disorder and gaming disorder, very similar. We're still dealing with a dysfunction in the dopaminergic system, but the intrusions are about, I need to do this right now. I need another hit, not I need this in order to avoid something really, really bad happening. Schizophrenia spectrum disorders. People with schizophrenia spectrum disorders have other symptoms in addition to the obsessions and compulsions and may not spend as much time engaging in those behaviors. So, yes, people with schizophrenia spectrum disorder may have some delusions and they may engage in compulsive behaviors in order to try to prevent that from happening. But we want to recognize that there's more to the diagnosis of schizophrenia spectrum disorders than just the delusions and obsessive compulsive behaviors. People with autism spectrum disorder may engage in a repetitive pattern of behavior. However, this is not in order to address obsessions. So they may have some compulsive habits that they engage in, but that's part of ASD, and or it can be part of ASD. They have symptoms of autism spectrum disorder, which you're going to see. Cocaine, opioids, and amphetamines can also contribute to skin picking. And I talked about this a bit already, but it's a really common feeling like maybe they've got bugs crawling under their skin or being really itchy. So I made you this Venn diagram to, I think, help suss out some of the overlap. And I added ADHD in there since there's a considerable amount of associated features overlapping with all of them. But paying attention to PTSD, there's a lot of overlap between symptoms of OCD and PTSD, like intrusive thoughts and doing things to avoid those intrusive thoughts or make those intrusive thoughts go away. It's very common in PTSD as well as in OCD. So they found this particular study of veterans that on a self report measure, 81% of the veterans that met criteria for PTSD and 74% met criteria for obsessive compulsive disorder. Does that mean that this many people had both of these disorders comorbid, or does it mean that the sensitivity or the validity of the self report measures might be called into question? Because there's so much overlap between the symptoms that a self report measure may not capture accurately or adequately. I don't know. But either way, it's important to recognize that these two either go together frequently or they overlap quite a bit. And looking at the research, a lot of the treatment for OCD and PTSD are very similar. So, again, let's look at the symptoms to try to figure out what treatment strategies are best going to help this person address their particular symptoms. And this is really fascinating and really important for us to know that people with obsessive compulsive disorder, the current suicidal ideation rate at any point in time is roughly 26%. So a little bit more than 1 in 4. And that's a lot. Lifetime suicidal ideation is 44%. So for people who've had OCD at some point during their life, 44% have had suicidal ideation. Lifetime suicide attempts is 14.2, and that's more than 1 in 10. Lifetime suicidal ideation for people with trichotillomania or excoriation is 40%. Attempts are right around 14%. It's important for us to recognize suicidal ideation for OCD, and trichotillomania is in the 40th percentile area. And that means that almost half the people that have this diagnosis were going to experience suicidal ideation at some point. We need to do a better job at screening for it in order to help them um, provide them tools and a sense of hope and support. Body dysmorphic disorder has a lifetime suicidal ideation rate of 74.5%. And I know we didn't cover that a lot today. However, it's in this category, and there is significant overlap with trichotillomania and excoriation disorder. Therefore, I think it's important to recognize that there is definitely a high risk of suicidal ideation, and suicide attempt rate is 35%, which goes even higher if the person also misuses substances. That's a lot if you're treating body dysmorphic disorder. It's not a diagnosis of vanity. It's a diagnosis that, you don't want to take lightly, because especially in our society of Instagram and social media and Facetune and everything else, the emphasis that's put on appearance. Our society is very challenging for people with body dysmorphic disorder, and you can see how easily they could spiral into suicidal ideation, depression, hopelessness, helplessness. Hoarding disorder, interestingly enough, has a lifetime suicide attempt rate of 24.1%. Why is hoarding disorder's attempt rate so much higher than OCD? What may have happened that predisposed that person to hoarding disorder, or what might be going on in hoarding disorder that increases their suicidal ideation and suicide attempt rate so much? Comorbidities. Now, these are things that occur with obsessive compulsive and related disorders. 76% of people who have one of these disorders also has anxiety. 63% has depressive or bipolar disorder, 56 have an impulse control disorder, 39% have substance use, and interestingly, 30% have a tic disorder. So we want to assess for tics when we're doing our intake, because it's important that if we have somebody presenting with tic disorder, we also assess for obsessive compulsive and related disorders, because they go together 30% of the time. Treatment for obsessive compulsive and related disorders is pretty straightforward, I guess, as SSRIs and SNRIs, as far as pharmacological interventions, still seem to be first-line treatment for OCD. The dosage tends to be much higher in OCD than for other disorders. An article that I came across, and this is not in the DSM-5 TR either, numerous drugs such as atypical antipsychotics, which play on dopamine levels, can cause or exacerbate OCD symptoms. So you might be like, well, if I'm not dealing with somebody with schizophrenia, then it's irrelevant, right? I know a lot of atypical antipsychotics are prescribed off label for sleep related disorders, restless leg syndrome. There's a variety of other situations in which atypical antipsychotics specifically may be used. So, the common ones that you'll bump into often are Abilify, Zyprexa, Seroquel, and Risperidol. Parkinson's disease involves disruption of the dopaminergic system, and in treating the Parkinson's disease, when the medications start altering the dopamine levels in the person's brain, you may see the onset of OCD symptoms, and that's definitely something that needs to be discussed with the person's doctor if especially their primary diagnosis is Parkinson's disease and symptom onset came right after or shortly after the beginning of a medicine treatment. So, some of the antidepressants approved by the US Food and Drug Administration or the FDA to treat OCD include SSRIs, SNRIs like Prozac, Luvox, or Luvox. I'm not really sure how you say it, Paxil, Zoloft, Celexa, and Lexapro. And when patients were asked about how they were doing compared to before starting treatment, they report marked to moderate improvement after 8 to 12 weeks on an SSRI. So, notice that that's like 2 to 3 months. And usually the maximum benefit is only seen after about 12 weeks. So, they really need to commit to taking this medication before really noticing that it might work or not. 3 months is a long time to be seeing something without results. And, sometimes it even can take as long as 6 months. At least 60% of people will have some improvement with medication on their first try. Most people have some improvement, although fewer than 20% of those treated with medications alone will have a complete remission of symptoms. And that's why medication is often combined with cognitive behavioral therapy to get more complete and lasting results. About 20% of people don't experience much improvement at all with the first SSRI and may need to try another one. Treatment options for obsessive compulsive that aren't medications include cognitive behavioral therapy, like I said, and that's in terms of addressing the non-neurochemical. So, backward chaining can be really helpful to encourage the person to identify vulnerabilities. What things happened that made you more prone to having these obsessions today? What things happened that led up to this particular belief, right? We're starting at what we think is the beginning of the day or, the experience altogether, and then moving forward from that. Exposure and response prevention or systemic desensitization can also be very, very helpful if they have the compulsion to do something and they're prevented from doing it. In order to help them through this process, though, in order to help them tolerate the obsessions, in order to help them not to engage in the compulsive behaviors, breathing is very important. Respiratory vagal nerve stimulation is, deep breathing, and deep breathing actually triggers the vagus nerve and the rest and digest, which is the opposite of fight or flight. So rest and digest, which can help people tolerate the stress response when they have obsessive thoughts or are prevented from engaging in compulsive behaviors. So maybe you're also looking into polyvagal theory when you're looking at, this respiratory vagal nerve stimulation. Distress tolerant skills such as distress tolerant thoughts, activities can be helpful as the person distracts themselves. Guided imagery to help them envision getting through a particular situation or envisioning a safe place. And sensations like splashing cold water on their face can be helpful during this response prevention period. Unhooking, or we talked about uncoupling, is another thing that's helpful for both obsessions and compulsive behaviors. Unhooking means believing that this thought is not part of me. I'm having a thought. I am not a thought. So, what will I do with the thought? The compulsion is not part of me. The compulsion is separate from me. I don't have to act on it. I'm having the desire to engage in a behavior. I don't have to do it. What am I going to do with it? I have a choice, right? So we're unhooking, we're uncoupling, and we're also giving the concept of choice back. Cognitive processing, going back to REBT, we can look at the ABCs, the activating event, your beliefs about the event, and the consequences. Or you can go more towards the FCP area, encouraging the person to look for facts for and against their belief, identify what they can and can't actually have control over, and explore the actual fact-based probability of their worst fear coming true. Cognitive restructuring can also be helpful with people, for example, who believe that if they don't wash their hands a certain number of times, they're going to get sick. They're probably going to get sick at some point. So cognitive restructuring can help them reframe that, with I took precautions so I didn't get sick and I kept myself as healthy as possible. And it's highly improbable to go in your entire life without getting sick. Journaling can also be helpful, especially when you're going through that response prevention. After the response prevention is over, have them journal what it felt like to have the thought to not be able to engage with the compulsive behavior, and then how do they feel now, even though they didn't or haven't gotten that ritual done or engaged in that behavior. Other treatment targets for cognitive distortions and obsessive compulsive and other related disorders include this overestimation of threat. This is where fact really comes in, based on the facts in the situation, how likely is it that this bad thing is going to happen? An inflated sense of responsibility. How responsible are they for this? They may say, if I don't do these 6 things, then something bad is going to happen to my significant other. They're going to get in a car crash or something. So we need to take a look at that. Your significant other is driving the car. Your significant other is responsible for defensive driving. How much responsibility do you have for preventing them from getting in a car accident when you're not even in the car, right? We're looking at fact and responsibility. Perfectionism is another cognitive distortion we need to address. How perfect does it need to be, or can we work towards good enough? And we want to help people learn how to tolerate uncertainty. We want to help them to examine whether having a belief is as bad as acting on it. A lot of people with obsessive compulsive disorder may believe that if they have this thought, they may as well have acted on it. Difficulty planning and organizing is another treatment target. This is more common in hoarding disorder, but not uncommon in obsessive compulsive disorder. And internalizing, I am responsible for these things. I am the one that did this. Personalizing, internalizing everything that happens. We want to help them unhook from these things and figure out, who they are, separate from their behaviors, separate from the things that they have no control over. Negative emotionality and neuroticism refers to how people perceive what is going on in their world. People who were engaged in this type of behavior tend to view things through a catastrophic lens. Instead of seeing things through rose-colored glasses, they're seeing things through mud-colored glasses. We need to help them to reframe and embrace concepts like radical acceptance, and also be able to view the entire picture, not just a certain set of data. And behavioral inhibition. A lot of people with obsessive compulsive disorder have a history of intolerance, of uncertainty, and it's important to help people develop the skills and tools they need to be able to tolerate life on life's terms, because there is a lot of uncertainty, and many times the compulsions are designed to help the person feel like they have a sense of control. Therefore, we need to help them figure out what they can do in their life in order to cope with unexpected events or in order to cope with uncertainty. Up to 60% of people with OCD report sensory phenomena such as feelings of incompleteness that precede compulsions and just right sensations upon resolution. According to the research, incompleteness may result from internalization of the OCD and association with baseline. This is what I do. This is what I've always done. If I don't do it, I don't know what else to do. Or they may have a lack of what one researcher called a stop signal. So they do something, but they need to keep doing it because they never feel like they've actually finished it or actually done it completely. The people with the lack of stop signal tend to experience incompleteness for certain. They don't often experience the just right sensation. They never feel just right, which is why they keep perseverating on the behaviors. And I didn't talk about nutrition and hydration in this one at all, but again, of course it's important. So this is your reminder right here, drink some water. And to summarize, obsessive compulsive and related disorders are extremely disruptive to the individual's life. It's important to engage in early intervention for obsessive obsessions and compulsive compulsions, even if they're not requiring more than an hour a day, to prevent exacerbation and development of comorbid issues. By the time somebody is engaging in compulsive behaviors more than an hour a day, it's already likely negatively impacting their life. So we want to catch them early. They're getting less sleep. They're not engaging in healthy behaviors the way they should. They're not doing things that work or the way that they're supposed to, or maybe they're even late for work. So it's negatively impacting their relationships because they're foregoing these things in order to engage in those compulsive behaviors or avoid things that might trigger the obsessions. Obsessive compulsive related disorders are often associated with a history of trauma, so attention must be paid to how behaviors create safety and how treatment can empower the individual to create safety in different ways. And I didn't mention this on the treatment page, but if somebody does have identifiable trauma that they've experienced, or whether they believe it's connected to their OCD or not, EMDR may be very helpful at helping them process those trauma memories so they feel safer. They can start processing their trauma sensations or trauma reactions, which may help to mitigate some of those obsessive compulsive behaviors.